And now we will hear from our myeloma update from Dr. Cohen.
Hi. All right. Well, again, it is my privilege to welcome another close friend and friend of the Nebraska Oncology Society. Dr. Adam Cohen is a hematologist at University of Pennsylvania, Penn Medicine. He currently serves as the director of myeloma immunotherapy. His areas of expertise are adult stem cell collection for transplantation, multiple myeloma, and Waldenstrom's macroglobulinemia. Dr. Cohen received his medical degree from the University of Pennsylvania. He later completed residency in internal medicine at University of Pennsylvania, followed by fellowship at Memorial Sloan Kettering Cancer Center for Oncology Hematology. In addition to his clinical position at Penn Medicine, Dr. Cohen also serves as an assistant professor of medicine at the Hospital of the University of Pennsylvania. Adam, welcome.
Thank you, Bernie, and thank you to the organizers for inviting me to speak with you here today. Let me just share my screen. Okay, hopefully everybody can see this. Give me one moment. Okay, so hopefully you all can hear me. So again, greetings from Philadelphia, and it's really a pleasure to be with you here today. I'm going to be giving an update on what's new in multiple myeloma, really focusing on data that was presented at the ASCO meeting just a few weeks ago. And these are my disclosures. So there really are actually a number of interesting presentations at ASCO this year, and this is an outline of what we're going to discuss. A few presentations focusing on newly diagnosed myeloma, including the E1A11 or endurance trial, which was presented at the plenary session. We'll discuss one abstract that looks at the role of stem cell transplant and maintenance therapy. One abstract, the Boston randomized phase 3 trial for early relapsed myeloma, and then a number of really interesting immunotherapies showing some promising initial efficacy in relapsed refractory myeloma. So when we think about our paradigm for treating newly diagnosed myeloma, we've traditionally divided patients up based on their potential eligibility for stem cell transplant. And so for transplant eligible patients, we think about induction therapy, 4 to 6 cycles, followed by consolidation with the stem cell transplant, in some cases with additional induction-like therapy, and then a maintenance program. And for transplant ineligible patients, we think about a longer period of induction therapy, moving on to maintenance treatment. And the most commonly used induction regimen in the US over the last several years has been the VRD or RVD regimen, bortezomib, lenalidomide, and dexamethasone. And this is just to remind you of some of the data supporting that. This is the long-term follow-up data from the SWOG 0777 study. This actually took both transplant eligible and ineligible patients, but the transplant eligible patients that agreed to defer transplant, they were randomized to either the VRD regimen for 6 months or just lenalidomide dex, and then all patients got lenalidomide dex maintenance. And what you can see on the bottom here is that there were higher response rates with RVD, higher progression-free survival, and importantly, improved overall survival. And this is one of the few studies in myeloma where changing the initial therapy, just 6 months of adding a proteasome inhibitor up front, led to an overall survival advantage. You can see, however, in this study, the rates of complete remission were relatively low, 8 to 16%. The other randomized data we have supporting RVD is this study from the French IFM group. This was a trial in only transplant eligible patients, so a younger, fitter population, median age closer to 60. Patients were randomized to either RVD for 3 cycles, transplant, RVD consolidation, and 1 year of maintenance, or just RVD for 8 cycles followed by maintenance. You can see in this study there were higher response rates, 50 to 60% CR rates, and an advantage for PFS for the early transplant group compared to just getting RVD followed by maintenance alone. No difference in overall survival. So this just provides a framework and background for what to expect with this regimen. Now, a question that's come up is bortezomib really the best proteasome inhibitor partner for lenalidomide and dex? And so there are a number of studies that have explored the use of carfilzomib, a next-generation proteasome inhibitor, in combination with Len-Dex, the so-called KRD regimen. You can see these are all smaller studies, all phase 2. The first two looked at both transplant-eligible and ineligible patients. The subsequent ones, which have been presented primarily in abstract form, looked at transplant-eligible patients. But the bottom line, if you look to the far right, is that in these studies, there seem to be higher rates of deep remissions. VGPRs are better, getting to 80 to 90%, higher rates of complete remission than historically described with VRD, and perhaps higher rates of progression-free survival. And so with this background in mind, I'll now review the ECOG E1A11 study, which is really the first randomized study comparing these two different proteasome inhibitors in combination with lenalidomide and dex in a randomized phase 3 fashion. And this was presented by Shaji Kumar at ASCO. And so this is the schema of the study. Patients with newly diagnosed myeloma, but importantly with standard risk myeloma, and I'll go through that in a moment, were randomized either to VRD regimen with bortezomib given on the typical 1-4-8-11 cycle, and initially this was given intravenously when the study was designed, and then patients could get subcutaneous bortezomib when that was available. Or they got carfilzomib given at 36 milligrams per meter squared on the traditional 1, 2, 8, 9, 15, 16 schedule Q28 with len and dexamethasone. Patients were treated for a total of 9 months of induction. There then was a second randomization to lenalidomide maintenance for 2 years versus lenalidomide maintenance indefinitely. And the study was actually powered to answer 2 questions. The first primary endpoint was PFS based on the randomization to VRD versus KRD, and it was powered to look for superiority of the KRD regimen. That was the hypothesis. There's a second, again, randomization looking at duration of maintenance, and that question was not addressed in this presentation. So this is just to give you a sense of the demographics. And again, I'll mention that the high-risk patients were excluded from this study. At the time of study design, it was decided that ECOG would lead a study for standard risk patients and SWOG would lead a study for high-risk patients. And I'll review that study next in the next presentation. And so this is really for patients who did not have these high-risk cytogenetic features, with the exception of 414, you can see on the very bottom, because these patients tend to do well with the proteasome inhibitor-based regimen, they were included and comprised about 10% of the population. Otherwise, you can see the median age was about 65, about 30% of patients were over the age of 70, and again, about 25% had ISS stage 3 disease. And again, this was a mix of patients who were both transplant ineligible as well as transplant eligible who agreed to defer transplant for later. So this is looking at the response rates and toxicities. On the left, you can see that the overall response rate was not different between the 2 arms, looking at just partial response or better, but the VGPR rate in terms of getting that deep remission was somewhat improved in the KRD arm compared with the VRD arm. Relatively low numbers of complete responses seen in this study. And on the right, you can see really the differences in toxicities with these regimens and sort of what we expected based on previous studies with bortezomib-based regimen, the VRD having higher rates of all-grade neuropathy, 53 versus 24%, higher rates of grade 3 and higher neuropathy, whereas the KRD regimen had higher rates of cardiopulmonary and renal toxicities, including dyspnea, hypertension, heart failure, and acute kidney injury, and this was 16% for KRD for grade 3 and higher versus 5%. It's important to mention that in this cooperative group study, a significant proportion of patients were unable to complete the planned 36 weeks of induction. Only 43% completed the VRD, and this likely reflects the use of the twice-weekly bortezomib schedule for the entire 9 cycles, which is somewhat difficult to complete. And 62% completed KRD. There was a slight increase in the percentage of patients who discontinued VRD due to toxicity or patient choice compared to KRD. But in terms of the primary endpoint of the study, you can see on the left here that there was absolutely no difference in progression-free survival between the 2 arms. It was about 34.5 months for both of these arms. On the right, you can see the forest plots looking at progression-free survival. And really looking at all these different subgroups, there was no statistical difference with one favoring one treatment over the other in these different subgroups. I will draw your attention, however, to the metaphase cytogenetics. And so I mentioned that high-risk FISH was an exclusion for this study, but some patients did have abnormal metaphase karyotype, which often confers a higher risk And there seems to be a trend where the patients with higher abnormal karyotype may have done better with Carity, whereas those with normal cytogenetics did better with VRD. But of course, this was an unplanned subset analysis and should be taken with that grain of salt. Importantly, there's been no difference in overall survival, at least so far at 3 years, between the different groups. And I will mention that despite the fact that there was an intention not to proceed to stem cell transplant at enrollment, about a quarter of patients did ultimately get a stem cell transplant. Now, some of these were salvage when they progressed, but some of them were taken off study to go for transplant. These PFS data were not censored for transplant that I'm showing you here, but there were equal numbers of patients in each arm who went off study for transplant, and it didn't appear to affect the overall analysis. And so in terms of the conclusions that I take away from this study, so it did fail to meet the planned endpoint of showing improved PFS for KRD versus VRD. And so both of these appear to have equivalent progression-free survival as a primary therapy in this standard risk population. And I think this does support continued use of VRD in this population, acknowledging though different toxicities with more neuropathy in the VRD population and more of the cardiopulmonary toxicities in KRD. Now, what about monoclonal antibodies? I've talked about changing the proteasome inhibitor, but we know that the addition of daratumumab, the CD38 antibody, to upfront therapy has demonstrated improved outcomes in several other randomized trials. So in the non-transplant eligible, we've seen data that adding daratumumab to lenalidomide dex, the DRD regimen, or adding it to bortezomib, methylprednisolone, the VMP regimen, improved response rates as well as PFS in those studies. I'm showing you data here from the Cassiopeia trial, which was a European study for transplant eligible patients, where daratumumab was added to bortezomib thalidomide dex, a PI-IMiD triplet, both as pre and post-transplant consolidation therapy. And in this study, there was an improvement not just in response rate, but depth of response, MRD negativity, as well as progression-free survival, with no difference in overall survival so far at a relatively short follow-up. And we don't use much VRD in the United States, so the data that we have looking at the addition of daratumumab to VRD is from the Griffin study, and this was a randomized phase 2 trial presented at ASH last year and just published online in Blood. In this study, these were transplant eligible patients. They received either VRD alone or VRD with daratumumab, both before and after autologous stem cell transplant, followed by daratumumab and lenalidomide maintenance in the dara arm and just lenalidomide maintenance in the lenalidomide arm. And you can see on the right that the addition of daratumumab improved the response rate up from 92 to 99%, improved the depth of response. No difference, however, in progression-free survival so far at this initial analysis. Now, this is a randomized phase 2 study. There is a follow-up randomized phase 3 trial that's accruing largely internationally, that's using the subcutaneous daratumumab, but with a very similar design, and will be able to tell us really the benefit of adding dara to our VRD regimen up front. So what was new at ASCO this year in terms of adding antibody-based therapies for newly diagnosed myeloma? So there are other antibodies, of course, besides just dara. This was the analysis of the SWOG randomized phase 2 trial, adding elotuzumab, which is the anti-SLAM-F7 monoclonal antibody, to the VRD regimen for newly diagnosed patients with high-risk myeloma. And so these patients, again, were selected for some high-risk criteria, either poor gene expression profile score, one of these high-risk translocations, or 17p deletion, or amplification of 1q, or plasma cell leukemia, or high LDH, patients who traditionally have done poorly with our standard approaches. And I'm not going to go through all of the details of study design with this, just because this also was a negative study. There unfortunately was not a benefit of adding the elotuzumab to the RVD regimen in terms of progression-free survival, which was the primary endpoint of this study, and relatively short PFS in this population, despite the fact that all these patients got continuous therapy until the time of progression with either the triplet or quadruplet. And so again, we still need better approaches for these high-risk patients. So one of these approaches is reflected here in this abstract by the German group. This was actually adding a different CD38 antibody called isatuximab. Isatuximab has recently been approved for relapsed refractory myeloma in combination with pomalidomide and dexamethasone. And so this study looked at adding isatuximab up front, not to VRD, but to the KRD triplet. And again, focusing on high-risk multiple myeloma patients. And so this is the schema of the study. It's a little bit complicated, but patients had to have some high-risk feature based on FISH, and these are shown here. If they're transplant eligible, they received 6 cycles of isatuximab with KRD, followed by 1 or 2 autologous transplants, ISA-KRD, consolidation, and maintenance. So a very intensive program. If they're transplant ineligible or older, they ended up getting 12 cycles of the ISA-KRD, followed by ISA-KR maintenance. And this was a planned interim analysis that was presented at ASCO, so only 50 patients available so far, with the response after just the induction cycles, but demonstrating that just with the induction, even before transplant, 100% response rates, more than 90% VGPR, almost 50% CR rates, and 2/3 patients achieving MRD negativity during the induction. And so I think, again, a promising approach for this high-risk group, but really very preliminary data, and we certainly need longer term follow-up after the consolidation and maintenance to look if this improves PFS. And in terms of the safety of this approach, adding the CD38 antibody did not appear to really increase the toxicity we might expect from KRD alone. The rates of grade 3/4 cytopenias were fairly similar, rates of infection, and you can see again some of these cardiopulmonary toxicities, hypertension and cardiac failure that we expect with KRD, again, not significantly increased with the addition of the CD38 antibody. And so now there are a number of randomized trials going forward, adding a monoclonal antibody to either VRD or KRD for newly diagnosed myeloma patients. And these are still accruing currently, and we're awaiting longer-term follow-up to get the sense of how much benefit patients are going to get from this approach. Now, moving on to the role of stem cell transplant in maintenance, this is the BMT-CTN0702 trial. This trial has been, the primary analysis of this trial has been presented and published previously. This was asking the question of, for patients who undergo an autologous stem cell transplant, what is the role of consolidation therapy, either with a second transplant, the so-called tandem transplant approach, with 4 additional cycles of VRD, or just moving directly to maintenance. And this was a US study, and the primary analysis showed no difference in progression-free or overall survival based on intention to treat in this study, which was a US patient population. Now, in this study, lenalidomide maintenance was planned for 3 years and then was supposed to stop. However, as data was emerging that perhaps longer-term maintenance therapy may be beneficial, there was a second long-term follow-up study that was added on that allowed patients to continue lenalidomide maintenance after 3 years, assuming they were progression-free. And so the analysis presented at ASCO by Dr. Harry and colleagues this year looked at the outcomes of patients who opted to continue lenalidomide maintenance versus those who decided to stop lenalidomide maintenance at the 3-year mark. And so this is a landmark analysis. It's not a randomized comparison, so take that with a grain of salt. There may be a selection bias in who chose to continue maintenance and who did not. But it was trying to get at this question that is common in practice. A patient's been on len maintenance, they've been progression-free for a few years, and they're saying, "Doc, do I have to keep taking this drug, or can I stop it?" And you can see that in terms of the group that continued len maintenance versus the group that stopped, they were balanced in terms of which original arm they were assigned to and whether they had high risk or standard risk cytogenetics. But we don't really have granular data about the dose of lenalidomide maintenance that they were on at the time that they were entered this landmark analysis. The bottom line, though, and the primary finding of this was that the progression-free survival was improved in the group that chose to continue lenalidomide maintenance versus the group that stopped at 3 years. And you can see whether we're looking at 4-year, 5-year, or 6-year analyses, about a 20% absolute increase in the percentage who remained alive in progression-free if they continued len maintenance. A similar magnitude of benefit was seen whether they had high risk or standard risk disease, although this was not statistically significant in the high risk group, likely due to smaller numbers. And so this does show that if you continue len maintenance, you have a higher chance likely of staying in remission compared to a patient who decides to stop after 3 years. That being said, however, there is no overall survival difference, at least so far in this analysis, perhaps a trend occurring in the standard risk patients, but at least with 6 years of follow-up, this didn't appear to appreciably change overall survival. Another important question was, if I stop len maintenance at 3 years, does that impact my risk of getting a second primary malignancy compared to continuing on? And at least in this analysis, there was no difference in the frequency or type of second malignancies in patients who continued maintenance beyond 3 years versus those who stopped. So what's my takeaway from this? Again, I think it depends a little bit on your point of view and how much you value PFS versus overall survival. I think you can tell patients that staying on maintenance sort of indefinitely until progression does seem to improve their chance of remaining in remission. But there's not an overall survival advantage in patients who are having significant toxicities or quality of life issues. I think you could stop with the hopes and plan to then restart a lenalidomide-based combination at progression. And I will say that there are now randomized studies that are ongoing, really asking this question in a prospective fashion that will obviously guide us better than this landmark analysis, and we're awaiting those data. So how can we incorporate some of these data into how we approach newly diagnosed myeloma today? And I think this is just one proposal. There are several others out there, but I really think if we think about either transplant eligible or ineligible patients, for our standard risk patients, the VRD regimen continues to be a standard of care based on the E1A11 trial, and you could use this either at the intensive dosing as seen in the trial or as a VRD light type regimen, which has been shown to have nice efficacy in patients that are more frail or have poor performance status using weekly bortezomib and lower doses of len and dex. I think the addition of daratumumab to a VRD triplet is something you could consider based on extrapolating from the Cassiopeia Dara VTD data or the early results of the Griffin trial. But again, we don't have randomized phase 3 data yet. So I don't know that this is mandatory. And then for high-risk patients, these still tend to do poorly, even with VRD type approaches. And some centers are still proposing using KRD in that setting, acknowledging the absence of a randomized trial to support that, mostly based on phase 2 studies. And also, this is an area we consider using the quadruplet in our high-risk patients, adding daratumumab up front. And particularly with subcutaneous daratumumab becoming available, this will make this a lot easier for patients. I think on the right, if you look at the transplant ineligible patients, I mentioned the VRD data based on the SWOG study, and the DRD, daratumumab lendex, based on the MAIA trial, showing a significant advantage over lendex alone, I think is another good option for these patients. But just remember that the data shown in that study were based on getting daratumumab and lenalidomide dual maintenance, compared to just len alone in some of the other studies. Now, moving on to what's new in relapsed refractory multiple myeloma. So the first abstract I'll talk about is this one from Demopoulos et al., looking at a newer drug for myeloma called selinexor. Selinexor is really a novel mechanism. It's an XPO1 inhibitor, and so it actually impacts the export of certain nuclear proteins, including tumor suppressor genes and other transcription factors in and out of the nucleus. And by doing so, it's been demonstrated to increase apoptosis and decrease proliferation of myeloma cells. And selinexor dexamethasone is now approved in the United States for really highly refractory patients that have had at least 2 proteasome inhibitors, 2 different IMiDs, and a CD38 antibody. And in the FDA-approved label, it's given as a twice-weekly dose with a significant amount of GI-type side effects. And so at ASCO this year, we saw the first results of the Boston randomized phase 3 trial. This was for a less heavily pretreated group of patients with only 1 to 3 prior lines of therapy. And it was a comparison of selinexor, bortezomib, and dex versus bortezomib dex alone. And what was interesting is that the selinexor was given just once a week based on phase 2 studies showing that it was better tolerated when combined with bortezomib in this once-weekly fashion. And the bortezomib was given once weekly. Still fairly intensive dexamethasone dosing, whereas the VD arm used the traditional bortezomib day 1, 4, 8, 11 schedule on a 21-day cycle. Treatment was given until progression, and the primary endpoint was progression-free survival in this study. You can see that the trial enrolled close to 400 patients. A fair number of them had high-risk cytogenetic features. About half of them had 1 prior line of therapy, and about a third had 2 prior lines of therapy. So again, not a very heavily treated population. 80% had had prior proteasome inhibitor exposure, although they couldn't be refractory to bortezomib on the study. You can see very few patients had daratumumab, and about a third had lenalidomide. And these are the primary results of the study. The study did meet its primary endpoint, including an improvement in progression-free survival, a median of 14 months versus 9.5 months with a hazard ratio of 0.7. You can see on the right, the overall response rate was higher in the SVD arm, 76% versus 62%, including a higher proportion of patients getting a VGPR or complete remission. And so the study did meet its primary endpoint, and this has led to submission to the FDA for possible registration. The issue, though, with this regimen, unfortunately, is the toxicity. You can see that the addition of selinexor had a significant increase in the rates of cytopenias, including grade 3-4 thrombocytopenia, and a number of patients were required to have thrombopoietin receptor agonists, as well as platelet transfusions. And then, as I mentioned, while the weekly schedule of the selinexor can mitigate the GI toxicity, this is still an issue with this drug. You can see close to 40 to 50% of patients with nausea, decreased appetite, diarrhea, and 20% vomiting. Several of these grade 3-4, fatigue and asthenia also an issue. And so I think this is a potentially valuable regimen, particularly for patients who have become refractory to many of our standard therapies. And I think with aggressive supportive care, which often can involve 2 or sometimes 3 antiemetics or appetite stimulants, patients can get through this regimen. But personally, for me, this is not something I think I'm going to be reaching for in my first relapse patients, or even second relapse, and something that we tend to save once patients become a little bit more resistant to standard proteasome inhibitors, IMiDs, and CD38 antibodies. Now, moving on to more heavily refractory myeloma patients, I think this is really where there's a lot of excitement in the field in terms of a number of novel immunotherapies for multiple myeloma that are showing exciting early results. And I will, of course, state I'm somewhat biased here since I do immunotherapies, but I really think we're seeing some unprecedented responses in highly refractory patients. And so I'll show you a little bit of data from what are called the CELMoD agents. These are really next generation IMiDs or immunomodulatory drugs. They are more potent in vitro than pomalidomide or lenalidomide at binding to cereblon, at causing anti-myeloma activity, even in len and pom resistant setting. And we heard about iberdomide or CC220 at ASH showing activity, and I'll show you the first data with CC92480. We've also heard previously about belantamab mafodotin. This is an anti-BCMA antibody drug conjugate that has shown activity in heavily refractory myeloma and has been submitted to the FDA for registration. I'll show you some data about several BCMA CAR T cells, including one of the largest phase 2 study with the idacaptogene viclucil or BD2121 CAR. And then I think what's really exciting, some of the newer data with the bispecific antibodies or T-cell engagers, several of which have been presented at ASH or ASCO over the last year, and I'll be focusing on the Teclistamab data that was presented at ASCO this year in a special scientific session. So first, looking at the CELMoDs. So again, these are drugs that are structurally similar to the IMiDs or like pomalidomide or lenalidomide, but appear more potent in preclinical studies. They're oral, and in this phase 1 study, were explored in several different schedules. A more typical IMiD-like schedule, either 10 out of 14 days, or a 21 out of 28-day schedule once a day, or more intensive schedules with twice daily dosing, again in combination with dexamethasone in highly refractory myeloma. I'll tell you the more intensive schedules were really not well tolerated based on cytopenias, and so going forward in expansion in phase 2, it's largely going to be these once daily dosing. A total of 76 patients were enrolled, and you can see heavily pretreated patients, about 70% were refractory to a CD38 antibody, 50% we call triple class refractory to a proteasome inhibitor, IMiD, and CD38 antibody. And these are the response rates. I think if you look at on the far left, in the overall population of 76 patients, there was a 21% response rate. If you look just at the more efficacious doses, once daily dosing, either for 10 out of 14 days or 21 out of 28 days, again, very small numbers in these groups, but 40 to 50% of patients responding, including some patients achieving complete remissions. And so this has now moved towards expansion and phase 2 studies, and we'll get a sense of whether these response rates hold up and how durable they're going to be in this heavily pretreated group of patients. In terms of the adverse events, the toxicities of these drugs seem somewhat similar to those we expect from IMiDs in this population, namely cytopenias, though I'll note that there was a fairly high amount of grade 3-4 neutropenia, over 60% of patients, and this drug, at least in this population, may require the use of G-CSF support, which was allowed after cycle 1. In terms of infections, 71% had any infection, including about 35% with grade 3-4 infections, and so certainly something we're going to have to keep an eye on in this population. But not a significant amount of neuropathy. GI toxicity was seen, but relatively low grade in about a quarter of patients. So stay tuned. Now moving on to my favorite topic, which is how do we redirect T cells to attack myeloma? And I think there have been two broad approaches, namely CAR T cells and the use of bispecific antibodies or T cell engagers. And again, you're all probably familiar with this, but just as a brief refresher, on the left, you'll see that the mechanism of action of CAR T cells, where autologous lymphocytes are taken from the patient by apheresis. They're genetically modified to express a novel chimeric antigen receptor, which now can recognize any surface marker that you'd like. In myeloma, most of the studies have been focusing on BCMA, which is a plasma cell marker. These cells, though, need an expansion and manufacturing process that can take anywhere from 2 to 4 weeks before they're finally reinfused into the patient, typically following some lymphodepletion. And so the advantage of this is that it's really a one-time treatment, and then you can stop, and patients really do appreciate that, especially if they get into a durable remission. The downside, of course, though, is that it does require this delay, and not every patient has their disease able to stay stable enough for that manufacturing period in order to get their cells. On the right, you have the bispecific antibody constructs. This is the same idea. You're trying to activate T cells to attack the myeloma, but instead of taking the cells out and manufacturing them, you provide a bispecific product where one end attaches to the myeloma cell, the other end attaches to CD3 on the T cells that are already in the marrow microenvironment, activates those T cells, creating an immune synapse and killing the myeloma cell in vivo. And again, the advantage here is that this is an off-the-shelf product. You can start it right away and start treating your patients without that delay. The downside is that this requires repeated infusions of the drug. And the canonical bispecific antibody that's already FDA approved is blinatumomab. This is one of these short half-life BiTE molecules that's approved for ALL and targets CD19 and requires a continuous infusion via a pump. And so it's a very cumbersome for patients. And so at ASCO this year, we heard the first data for a novel BCMA CD3 bispecific antibody called Teclistamab. And this is really where the field is going, getting away from the short half-life BiTEs to these longer half-life, more IgG-like molecules that have an FC portion that provides greater stability in serum and allows for more convenient dosing, more like a typical monoclonal antibody. And this product is dosed once a week. This targets BCMA, so again, you're trying to bring the T cell to the tumor cell, in this case myeloma, and trying to kill it. And so we heard data from this phase 1 study at ASCO this year. These were relapsed refractory patients without additional therapeutic options, a typical dose escalation study. As with most of the bispecific antibodies, this study utilized what's called step-up dosing. And this is because of early observations that if the full dose was given right from the start, patients had a very high rates of cytokine release syndrome or even neurotoxicity. And so in order to mitigate that, most trials are starting with very low doses with the first dose, and then over the first week, gradually giving 1 or 2 additional doses, stepping up until you finally reach the target dose, which starts on week 1, and then this study was given weekly thereafter. With this approach, the toxicities appear to be mitigated. And so this study, this presentation at ASCO covered 78 patients. The median age was 62. You can see median prior lines of therapy of 6, so a very heavily treated group, 80% triple class refractory, 86% progressing on their last line of therapy. So this is truly our unmet need in myeloma patients without good other options. In terms of the safety profile, interestingly, there was a fair amount of cytopenia seen with this drug, and this is thought to be likely cytokine mediated. We can see this with CAR T cells as well, where you can get some suppression of normal hematopoiesis in this study. Cytokine release syndrome was seen in about 56% of patients, though importantly, no patient had grade 3 or higher CRS. This is likely due to us becoming more comfortable using tocilizumab or even steroids early on to intervene in these patients before it becomes more severe. And you can see about a quarter of patients received tocilizumab. But very few other high-grade toxicities were seen. Infections were seen in 65% of patients overall. About 20% were grade 3 or higher. And this remains an issue with these relapsed refractory patients. And there were 6 patients who did have some neurotoxicity. 4 of these were short-lived, low-grade events. 2 patients, though, did have more higher-grade encephalopathy or neurotoxicity-like pictures that fortunately did resolve as their CRS resolved. And in terms of the activity of this drug, so there was no activity seen at the lower doses. In the intermediate doses, 30% of patients responded. But I think, interestingly, at the 270 microgram per kg dose group, again, only 12 patients, but 2/3 of those patients responded, including some VGPRs and CRs. And there's additional efficacy data that's maturing at higher doses. And I can tell you that the study is now pushing out to 1,500 micrograms per kilogram and even higher. And some patients did achieve MRD negative states, even in this highly refractory population. So it's very early days for this agent, but this, I think, confirms some of the other bispecific antibody data we've been seeing in multiple myeloma, and confirms BCMA is a good target for bispecifics. And we'll have to wait larger studies and longer follow-up to get a sense of how durable these responses are going to be. Moving now to CAR T cells, we previously had seen both at ASH and in a publication in the New England Journal about the early activity of this BCMA CAR T cell product called ide-cel, previously BB2121. And based on that early phase 1 data, this phase 2 registration study was initiated called KARMA. This enrolled patients who had had 3 prior regimens and had been exposed to an IMiD, a PI, and a 38 antibody. They were progressing on their most recent therapy. They all underwent leukapheresis and manufacturing. They could receive bridging therapy to control disease during manufacturing, and then got a single infusion of CAR T cells with fludarabine and cyclophosphamide lymphodepletion. And on the right, you can see this, the patient flow through. You can see 158 screened, 140 leukapheresed, and 128 treated. And this is, again, a common theme in CAR T cell therapy, that there is a subset of patients whose disease just progresses too rapidly, and they never end up getting their CARs. You can see that this study looked at different doses. The majority of patients received the 300 million or 450 million dose. And the median follow-up is somewhat different, but ranges between 12 to 18 months. 128 patients that were treated were included in this analysis. You can see, again, median of 6 prior lines of therapy, 94% refractory to a 38 antibody, 84% triple refractory. So that very difficult group to treat. And these are the key findings of the study. And this is the largest study of CAR T cells in myeloma that's been presented to date. The overall response rate was 73% with a CR rate of 33%. If you look at the upper right, you can see that there seems to be some dose dependence in terms of response rate, which was highest in the group that got 450 million cells, including almost 40% complete responses and 28% MRD negative. I'll state, though, this was not a randomized study or powered to really compare the 2 doses between 450 and 300. You can also see on the left the PFS curves. The median PFS for the entire study was about 8 months. But again, there appear to be some difference based on dose, with a median PFS of close to 12 months at the target dose of 450 million cells, which is the dose that's going forward in future trials. The adverse events seem to be similar to that seen in the phase 1 study and what we tend to expect with CAR T cell therapy in myeloma, namely cytokine release syndrome, which was seen in 84% of patients, 96% at the target dose. But again, only a handful of patients developing high-grade CRS. And this, again, is due to our more frequent and earlier use of tocilizumab. So half the patients did get toci, and this tends to prevent the development of grade 3 or higher CRS and does not appear to impact efficacy. About 20% of patients develop any neurotoxicity event. Again, the vast majority of these grade 1, 2, and reversible. And so based on these data, this product has been submitted to the FDA for a potential registration, and we're awaiting their review to see if this will become approved. Now, the other CAR product that presented new data at ASCO this year is this one called Orva-cel. This also targets BCMA, but is structurally different than the ide-cel product I just mentioned. It's a fully human BCMA binder. And they have a different manufacturing process. They actually isolate CD4 and CD8 cells after leukapheresis, and then put those together in a 1-to-1 ratio during manufacturing to allow more T-cell help while they make the product. And this is based on some prior correlative data suggesting this may be beneficial for persistence of the cells after infusion. And we previously saw data of this evolved study at ASH in 2018, and Shem Myeloma from Memorial presented an update at ASCO this year. Patients, again, had to have heavily pretreated myeloma, progressing on their last line of therapy. They got pheresed, bridging chemo, and then were infused with Orva-cel after a fludarabine cyclophosphamide conditioning regimen. We previously saw data on the 50 and 150 million dose level, and this was not presented today, at ASCO, and what they focused on were patients getting the 300, 450, and 600 million dose level. This was a phase 1 study, so primary endpoints were safety and the recommended phase 2 dose. There is a dose expansion that's underway as well. You can see 62 patients were included in this analysis, split between these various doses. The key takeaways, though, again, median of 6 prior lines of therapy, 94% penta exposed, 94% triple refractory. About half of these are penta refractory to 2 IMiDs, 2 proteasome inhibitors, and a CD38 antibody. So very tough to treat population. In terms of safety and side effects, I think similar to what we come to expect with CAR T cells, mainly cytopenias, which were high grade in the majority of patients, related both to the Cy/Flu conditioning as well as that cytokine impact on the bone marrow. All grade CRS was seen in 89% of patients, and all grade neurologic events in 13%, but you can see very few high grade events, grade 3 or higher, only in 3%. 3/4 of patients, though, did get tocilizumab, 52% steroids. There were 2 deaths on this study that were felt to be treatment related, including 1 patient who after CRS developed grade 5 macrophage activation syndrome, HLH, demonstrating still the potential risks of these approaches. And these are the data in terms of clinical efficacy. You can see on the right, the overall response rate was 92%. Including 68% with VGPR or better, and interestingly seemed to be fairly similar across the different dose levels. The follow-up was shortest at the 600 million dose level, so some of these patients may develop deeper responses over time, which is something we've come to see with CAR Ts. And on the left, you can look at durability of response for these patients. You can see at the 300 million dose group, the median PFS was about 9 months, very similar to the KarMMa study I just showed you with the ide-cel product. The follow-up is shorter in the 450 and 600 million dose group, so we need to wait and see if these higher doses are going to lead to a more durable remission duration in this with this particular product compared with some of the other products we've seen. But again, very, very strong efficacy with this product as well. And this is moving forward in a larger registration like phase 2s. And then finally, just a quick refresher on this product called JNJ-4528. This data was originally presented at ASH. It was just an updated ASCO this year, but this is, again, a BCMA-directed CAR T-cell product. It's structurally a little different than the other 2 that I showed you. But in this phase 1 study, again, very heavily pretreated patients, similar type of refractory population. There was a 100% response rate, and interestingly, a higher rate of complete remissions, now at 86%, which is stringent CR in these 29 patients in the ASCO update that was presented. Median follow-up is still short, only 11 months, 22 of 29 patients alive and progression-free with a 9-month PFS rate of 86%. So again, very, very short follow-up, and we need longer data, but this study is now expanded to include an additional 60 patients in a registrational phase 2, and we're awaiting that data to see if these data are going to look any different than the other CAR products that I just described. And so how do we put all these data in perspective with our approach to relapsed refractory multiple myeloma? And so when we think about treating patients who are relapsing, I tend to think of whether they're actually refractory to lenalidomide, are they progressing on a lenalidomide regimen or len maintenance, or are they not refractory? And if they're not, we have a number of the lenalidomide-based triplets that have shown efficacy in randomized phase 3 trials. The Dara-Lendex or Carfilzomib-Lendex appear to have some of the best hazard ratios in PFS data for more frail patients. Adding ixazomib, the oral proteasome inhibitor, or elotuzumab are also efficacious. And then for those that are refractory to lenalidomide, you really have a lot of options, a number of phase 3 trials showing efficacy. with daratumumab-based regimens in combination with bortezomib, pomalidomide, carfilzomib. You have a carfilzomib, pomalidomide, dex regimen, bortezomib, pomdex, and elo-pomdex. And so a lot of these options available. Once patients become more refractory, this is where I think some of the data I showed you today plays into a role. So I think maybe selinexor or bortezomib dex, once patients are becoming refractory to some of these other regimens. All of the BCMA-targeted therapies are fitting up here, including belantamab, which I didn't show you data on today. There was no update at ASCO, but that antibody-drug conjugate, several of the CAR products, and several of the bispecific antibody products. And then the novel IMiD, CC220 and CC92480, now called CELMoDs. Where are these going to fit in? And I think we have data with dexamethasone in highly refractory patients, and we'll be getting data soon on other combinations as well. And so a host of options available to us. I don't think ASCO really helped clarify how to best sequence these, and this remains really an individualized decision for each patient, and an area I think clearly we need further study. And so to conclude, what we learned at ASCO this year was that the VRD and KRD regimens have similar overall response rates and PFS for standard risk new myeloma patients, but there are different toxicity profiles as shown here. Adding elotuzumab unfortunately did not seem to benefit high-risk myeloma patients when given the VRD regimen. Adding isatuximab, a novel CD38, to KRD was feasible in that German study for high-risk myeloma, but we need longer data. The BMTCTN0702 long-term follow-up does suggest that prolonged len maintenance post-transplant improves PFS in that landmark analysis, but no improvement in survival so far. Data now that adding selinexor to bortezomib dex in a randomized trial improves response rates and PFS with the trade-off of GI toxicity and cytopenias. We have a novel CELMoD that has activity in relapsed refractory myeloma that seems promising, particularly at higher doses, and then a number of different BCMA-targeted immune therapies showing really unprecedented response rates and depth of response in relapsed refractory myeloma, including MRD-negative responses seen. And I think the big question for these products is what's the response durability going to be, and why is it so variable? We have patients that are out 2 or 3 years after a single CAR T-cell infusion doing great. We have others that are progressing in 5 to 6 months. And I think we really need a better understanding of biomarkers of resistance, understanding why patients respond or don't respond, and better ways to mitigate CRS and neurotoxicity as well. But I think these are really good challenges to have, and there should be a number of these on the market in the next year or so that will give us better options for our patients. And so I think with that, I'm going to stop, and I'm happy to take any questions.
All right, folks, if you have any questions, feel free to write them into the chat box. I'm not seeing any questions yet, Dr. Cohen.
Okay. It's been a long morning with a lot of talks, I'm sure. Well, I'm available if any questions come up. Folks can get my email from the organizers, and just thank you again for the invitation to come and speak with you here today.
Thank you so much, Dr. Cohen. We really appreciate your time.
Thanks, Adam.